Welcome to the Deep Dive. Today we're tackling something really challenging in medicine. Motor neuron lesions.
Yeah, these are tough. Conditions defined purely by loss of strength, loss of movement. It's a wide spectrum, too.
Exactly, from, sudden things hitting kids to these really slow genetic conditions, and then the really devastating adult diseases like ALS.
Right.
So our mission today, for you listening, is to give you that essential diagnostic toolkit. How do experts quickly tell these serious conditions apart, like acute flaccid myelitis, SMA type 4, ALS? We need the core rules.
And the place to start really is the basic wiring, the anatomy. You can't understand the problems without knowing the system.
Makes sense.
So think of voluntary movement like a two-stage command. Two key players.
Okay, stage one.
That's your upper motor neuron, the UMN. Think of this as the command center. These neurons live upstairs in the cerebral cortex, the brain.
Right.
And they're axons, these long wires. They run down to connect, eventually, in the brainstem or the spinal cord. They carry the main order.
So UMN is the signal from the top brass. What's stage two?
Stage 2 is the lower motor neuron, the LMN. These are the workhorses. They get the command from the UMN, and they're the ones that actually leave the central nervous system. Through cranial nerves, spinal nerves, they plug directly into the muscle cells. If the LMN fails, that muscle just doesn't get the message. No movement.
That distinction feels really critical already, because some conditions we're talking about, like acute flaccid myelitis or that adult onset SMA, they only hit the LMNs, the workhorses, right?
Exactly, LMN only.
But then the big one, ALS, amyotrophic lateral sclerosis, that one's especially tricky because it goes after both the UMN command center and the LMN workhorses.
Simultaneously, yes, that's what makes it so complex.
Okay, but before we even get into sorting which disease it is, what's the absolute first step if someone presents with, like, sudden really bad weakness?
Right. Immediate threat assessment. Before anything else, you have to think ABCDE.
Airway, breathing, circulation, the basics. Why is that the immediate priority here?
Because the same motor neurons that control your arms and legs also control swallowing and, crucially, breathing. If those are failing,
Respiratory failure.
it's a huge immediate risk. So if that patient looks unstable, forget the detailed neuro exam for a second. Stabilize them first. Intubation maybe, mechanical ventilation, IV fluids. Get them safe.
Because if they can't breathe, nothing else matters.
Yeah.
Okay, that makes total sense. So if they are stable, then we move to the history and the exam.
And then you can proceed, yeah. You start listening to their story. What are we looking for? Progressive weakness, usually bilateral, meaning both sides. Often they'll describe trouble with really basic things, getting out of a chair, walking, maybe using their hands.
Or speaking.
Swallowing.
Exactly. Trouble speaking clearly, that's dysarthria. Trouble swallowing, dysphagia. And critically, you need to pin down the speed. How fast did this come out? That's a huge clue for later.
Okay, speed is key. So let's get to that first big diagnostic filter. Before we even worry UMN versus LMN, how do we just rule out a whole bunch of other stuff? The sensory rule. This is probably the most powerful initial step. Motor neuron conditions, by definition, they cause pure weakness.
Pure weakness, meaning?
Meaning sensation is completely normal, intact. This is your shortcut.
Okay, hold on. So if a patient comes in, says, my legs feel weak and my feet are totally numb and tingling, we should immediately think not AFM, SMA, or ALS.
Precisely, immediately. If they report numbness, tingling, pins and needles. Or if you examine them and find they can't feel light touch or vibration or temperature changes, then you have to think about other things that hit both motor and sensory pathways, like maybe a lesion in the spinal cord itself, or, bilateral strokes, or demyelinating diseases like MS.
Wow. Okay, so the sensory rule is like a massive triage tool for the nervous system.
It really is. Very efficient.
So we've used the rule, sensation is normal. We're now focused purely on motor problems. How do we spot damage specifically to those LMN workhorses on the physical exam?
Right. LMN damage shows up in the muscle itself, basically because it's lost its power supply, its connection. There are 4 classic signs you look for.
Okay, what are they?
1, atrophy. The muscle just wastes away, gets visibly smaller.
Okay.
2, fasciculations. Those are the little involuntary twitches you can sometimes see under the skin. It's like the dying motor units are firing off randomly.
Right, I've seen those.
3, decreased tone or flaccidity. The muscle feels floppy, loose when you move the limb.
Okay.
And 4, hyperflexia. The deep tendon reflexes, like when you tap the knee, they're decreased or sometimes completely absent.
Atrophy, fasciculations, decreased tone, low reflexes.
Got it.
That's a clear LMN checklist. Let's use that now to differentiate the two pure LMN conditions you mentioned. They're mainly separated by timeline, you said.
Exactly. Let's start with the fast one. Acute flaccid myelitis, AFM.
The name kind of says it all, right?
Oh.
Acute sudden, flaccid, weak, and floppy, like those LMN signs. Myelitis involving the spinal cord. So, rapid onset.
Very rapid. Weakness progressing over hours, maybe up to a few days. And typically you see this in a child.
Okay. And what's the context? Does it just happen out of the blue?
Almost never. The key thing is there's usually something before it, a preceding event. Typically a fever, maybe with a respiratory illness like a cold, or sometimes a gastrointestinal thing like vomiting or diarrhea. It feels like a post-viral complication.
Ah, okay. So the body fights off a virus and then this happens. Which viruses are the main suspects?
The big ones we see are enteroviruses, specifically D68 and 71. West Nile virus is another one. And, historically, poliovirus was the classic example.
Right.
But thankfully, with vaccination, polio is incredibly rare now in most parts of the world. It's worth noting, too, enteroviruses and West Nile often pop up more in the summer and early fall. Sometimes that timing gives you a small clue.
Okay, so picture this. A child getting weak very quickly, pure motor weakness, no sensory loss, and they just had a fever and sniffles a week ago. How do we actually confirm it's AFM?
Two key tests: a spinal tap for CSF analysis and an MRI of the spine.
CSF, cerebrospinal fluid.
Yep. You look at the fluid bathing the brain and spinal cord. In AFM, you'll usually see what's called pleocytosis,
Which
which just means more white blood cells than normal in the CSF. It tells you there's inflammation in the nervous system, but usually not a bacterial infection. Typically, it's lymphocytes that are up, which points towards a viral or post-viral reaction.
Okay. And the MRI.
The spine MRI is crucial. It will show inflammation and damage specifically concentrated in the gray matter of the spinal cord. That's important because that's exactly where the LMN cell bodies live. It confirms the target of the attack.
Got it. AFM rapid, post-viral, LMN signs, confirmed by CSF and MRI showing gray matter involvement. Now let's contrast that completely with the other pure LMN disease, spinal muscular atrophy type 4, SMA4. This must be slow.
The absolute opposite. SMA4 is genetic, and it's defined by being incredibly slow. We're talking weakness that creeps up gradually over years, decades sometimes, not hours or days, and it usually presents in adulthood.
Years. If it's that slow and just feels like general weakness, I imagine it gets missed or misdiagnosed quite a bit at first. Maybe just put down to getting older.
Oh, absolutely. Very frequently, especially because it starts subtly. The key pattern to look for, though, is proximal weakness.
Proximal meaning.
Closer to the center of the body. So the shoulders and the thighs get weaker, often much more noticeably than the hands and the feet. The person might say, I have trouble climbing stairs, or lifting things overhead is harder now. But distal strength, like grip, might be relatively okay for a long time.
And they can usually still walk.
Generally, yes. They remain ambulatory, able to walk, often for a very long time, though maybe more slowly or with difficulty. It's not like the rapid paralysis of AFM.
And this all comes down to genetics. You mentioned the SMN1 gene.
That's right. The diagnosis is confirmed by genetic testing. You're looking for deletions or mutations in both copies of the survival motor neuron 1 gene, SMN1. This gene is critical for keeping lower motor neurons healthy.
And the type 4 relates to how severe it is.
Exactly. There's a severity scale, types 1 through 4, basically linked to how much functional SMN protein someone can make, often influenced by a related gene, SMN2.
Can you quickly run through those types?
Sure. Type 1 is the most severe, used to be called Wernicke-Hoffmann disease, infantile onset. These poor kids often can't even sit up independently and historically had very early mortality, usually from respiratory failure.
Oh, wow.
Type 2 is intermediate. Kids can sit up but typically don't walk. Type 3, they can walk but have progressive weakness. And then type 4 is our adult onset, slowest progressing, mildest form.
That's a huge range. What's really encouraging, though, is you mentioned treatments earlier. This isn't just managing symptoms anymore.
No, it's been completely revolutionized, actually.
Yeah.
We now have disease-modifying therapies. These drugs actually work to increase the amount of functional SMN protein in the body. There are 3 main ones approved. There's an antisense oligonucleotide called nusinersen. There's an oral mRNA splicing modifier called risdiplam, and there's even a gene therapy, onasemnogene abeparvovec, which tries to replace the faulty gene.
Gene therapy. Amazing.
Yeah. They aren't cures in the sense of reversing all damage, but they can significantly slow progression, improve motor function, and dramatically change the natural history of the disease, especially if started early. It's a huge leap forward for SMA.
Okay, so we've got the pure LMN scenarios covered. Rapid AFM, slow SMA type 4. Now let's make that shift. What happens when it's not just the LMN workhorse is failing, but the UMN command center is also under attack? That brings us to ALS.
Amyotrophic lateral sclerosis. Yes. This is where your physical exam skills become absolutely critical because you're looking for that dual signature. Signs of both UMN and LMN damage happening at the same time, often in the same limb or body region.
Okay, so we'll still see those LMN signs we talked about,
Mhm.
muscle atrophy, the fasciculations, maybe decreased tone in some areas.
You will, absolutely. The workhorses are definitely dying off, so you see all that. But because the UMN command center is also failing,
Mm-hmm.
you simultaneously see the classic UMN signs superimposed. And those are spasticity, where the muscles feel stiff, rigid, resistant to passive movement, and hyperreflexia.
Hyperreflexy. So instead of decreased reflexes like in pure LMN disease, the reflexes are exaggerated, like a really brisk knee jerk.
Exactly. Overactive reflexes. So finding that combination, the atrophy and fasciculations alongside the spasticity and hyperreflexia, and seeing it in multiple parts of the body, like an arm, a leg, and maybe the bulbar muscles, that's the clinical hallmark of ALS.
You mentioned bulbar muscles affecting the head and neck. That seems particularly prominent in ALS descriptions.
It often is. Patients develop that slurred, difficult speech dysarthria and sometimes a hoarse or strained voice. Swallowing problems, dysphagia, are also very common and dangerous.
And ALS isn't just about motor control, is it? There are other aspects.
That's a crucial point. No, it's not purely motor. There can be significant emotional and cognitive changes, too.
Is that the pseudobulbar effect?
That's one major component.
Yeah.
Yes, PBA. This manifests as emotional ability, like sudden, uncontrollable episodes of laughing or crying that seem way out of proportion to how the person actually feels inside. It's really distressing, and it's neurological, not psychological.
Wow. And cognitive changes too.
Yes. A significant number of people with ALS also develop cognitive impairment, which can range from mild executive dysfunction to a full-blown frontotemporal dementia, FTD. The overlap between ALS and FTD is well recognized now.
So it can really affect thinking and behavior too.
Oh.
Okay, so clinically you suspect ALS based on finding both UMN and LMN signs in multiple places, maybe bulbar symptoms, maybe PBA or cognitive issues. How do you confirm the diagnosis? What tests lock it in?
The key diagnostic tool here is electrodiagnostic testing. Nerve conduction studies, NCS, and electromyography, EMG.
What do those show in ALS?
Well, the EMG needle exam directly assesses the health of the muscles and the motor units. In ALS, it shows widespread evidence of denervation, meaning the muscles are losing their nerve supply. You see signs of both active, ongoing denervation and chronic, long-term denervation in multiple different body regions, like an arm, a leg, and maybe the bulbar muscles. That widespread pattern is key.
Okay, and the nerve conduction studies.
The NCS part is just as important for what it doesn't show. You'll typically find that the motor nerve response, the signals traveling down the motor nerves, are reduced in amplitude or maybe even absent, which fits with the motor neuron loss.
Right.
But crucially, the sensory nerve conduction studies measuring the signals in sensory nerves are usually completely normal. This electrically confirms our sensory rule. The sensory pathways are spared. It's a pure motor problem, electrically speaking. That combination of widespread motor denervation on EMG with normal sensory NCS is highly suggestive of ALS.
That makes sense. It backs up the clinical picture. It sounds like getting an ALS diagnosis must just trigger this massive cascade of needs for the patient. It's not just about finding a drug.
Oh, absolutely not. Management is fundamentally multidisciplinary from day one. Because the disease affects so many systems and progresses relatively quickly, you need a whole team.
Like who?
Physical therapy, occupational therapy to help with function and equipment, speech therapy for communication, and critically, swallow safety. Respiratory therapy is vital for monitoring breathing function and managing ventilation when needed. Dietitians for nutritional support, especially with swallowing issues. Social workers for support, resources, planning. It's a huge coordinated effort.
That comprehensive care seems essential.
Yeah.
Are there any medications that can actually slow the disease down?
There are a couple of disease-modifying therapies approved. Riluzole is an older one, and edaravone is newer. Neither are cures, let's be clear, but studies show they can slow the rate of functional decline modestly. They extend lifespan by a few months on average. So they're offered, but we need better options.
And what about for that pseudobulbar effect, the uncontrollable laughing or crying? Is there anything for that?
Yes, actually. There's a combination medication, dextromethorphan and quinidine, which is specifically approved for PBA and can be quite effective in reducing the frequency and severity of those episodes for many patients. It can make a real difference to quality of life.
Okay, so we've really covered the key distinctions now for these three major conditions. We had AFM, the rapid post-viral pure LMN attack, then SMA type 4, the super slow genetic pure LMN condition, and finally ALS hitting both UMN and LMN, progressing faster than SMA4 with that dual signature on exam.
Exactly. So just to synthesize it again for you, remember step one, is it pure weakness? Is sensation totally normal? If yes, you're thinking motor neuron disease.
Right, the sensory rule.
Then step two, look at the speed of onset. Is it hours to days? Think AFM, especially in a kid post-illness. Is it years? Think SMA type 4 or potentially ALS in an adult. And step three, look for the pattern of injury on exam. Is it only LMN signs, atrophy, fasciculations, low tone, low reflexes that points to AFM or SMA? Or are you seeing both LMN signs and UMN signs, spasticity, hyperreflexia together? That mixture is the big flag for ALS.
That's a really clear framework. Pure weakness, speed, and then LMN only versus UMN LMN mix. Before we finish, though, let's loop back to something you said earlier about UMN signs. In ALS, the chronic UMN damage causes spasticity and hyperreflexia.
Correct. That's stiffness and those brisk reflexes.
But you mentioned something interesting happens in acute, sudden UMN injuries, like a spinal cord injury from trauma or a big stroke hitting the motor pathways.
Ah, yes. This leads to our final kind of provocative thought for you. If chronic UMN lesions cause spasticity, why is it that a sudden, severe UMN injury initially presents with the opposite?
I mean, initially it looks like an LMN problem, like flaccid paralysis, decreased muscle tone, maybe even absent reflexes.
Exactly that. For hours, days, sometimes even weeks after a severe spinal cord injury or stroke, the patient is often flaccid below the level of the lesion. The nervous system goes into a state often called spinal shock. The expected UMN signs, the spasticity and hyperreflexia, they only emerge later as the nervous system reorganizes, often abnormally.
So the question is, why? Why does the command center, when suddenly knocked out, initially cause the workhorses to go completely limp before that hyperexcitable state kicks in?
Precisely. It's a counterintuitive finding that really makes you think about the immediate versus the long-term consequences of damage to different parts of the motor system. It just highlights the incredible complexity of neurological responses that we've only really scratched the surface of today, even when trying to define these UMN versus LMN injuries.
That is a fascinating point to reflect on. It shows things aren't always as straightforward as UMN equals spasticity right away. Well, thank you so much for sharing your sources and walking us through this complex topic. Hopefully this deep dive gives you, our listener, much better clarity on approaching these serious conditions.
My pleasure. It's important information to understand.
Absolutely. We'll catch you on the next deep dive.